Hello, welcome to HFMAtalk, the podcast for NHS Finance. I'm Sarah Day, Policy and Research Manager at the HFMA. As we start 2021 in a new national lockdown, we catch up with Sanjay Agrawal, Consultant in Respiratory Medicine and Intensive Care at University Hospitals of Leicester NHS Trust, to find out what this wave looks like from a clinical perspective and whether anything is different this time round. Hi Sanjay, thank you for joining us again today.
Hi Sarah, nice to be back with you again.
So I'm just interested really how things are going for you in Leicester and whether this is feeling different this time around for you.
Yeah, so I think it is different. So I think we last spoke probably about a month ago at the HFMA conference, and I would say things have changed quite dramatically, even in the past couple of weeks, and in fact even this week, in the last 5 days. So probably much like the rest of the country, we've had a massive upturn in people being admitted to the hospital with COVID-19 infection. And for me, that means also more people then being admitted to the intensive care unit with respiratory failure due to COVID-19. So this week, for instance, I've been on the intensive care unit, and we are now well over our normal intensive care bed base. We're going to start moving into other areas, as we did in the first wave, into theatre recovery, so that we can treat the increase in number of patients. We are now utilising staff from around the hospital to staff intensive care beds. We now have activated our resident consultant rotas at night. And at my age, I can tell you that that's it's not something that's especially welcome, but there you are. And so, yeah, things are very different to how they were just, a few weeks ago. I would say compared to the first wave, however, at least I can see light at the end of a very long tunnel with respect to knowing that there is a vaccine, it's being rolled out. But the reason I say it's a very long tunnel is because you still need the vast majority of the entire UK population to be vaccinated before it's going to make a big difference to our hospital admissions. So with the current R number and the increase in infectivity of the new variant, it seems to me that we are going to continue to have a lot of people becoming sick if they do not follow lockdown precautions. They will become sick, and a proportion will be admitted to hospital, and a proportion will come to our ITU. So that's predictable, and it's not great. Looking forward for the next few weeks. Exactly how long it's all going to last, it's hard to know, because it will depend on the R number, I suppose, and the infectivity of new strains. So that's kind of where we are. I would say we've gone sort of 2 steps forward with respect to having a vaccine, having some medicines that seem to help, but we've gone 1 step back because we've got a new strain that is really infective, and a large number of the population have become infected.
And have you seen admissions accelerate? The curves that we've been seeing on the news seem to have a much steeper gradient on them in terms of infection levels. Has it happened quicker than you would have expected from last time?
Quicker than I would have expected. I think, probably yes. I would say, the difference between Monday and Friday this week is quite obvious, let's say. It does seem to have been very quick. I suppose the lockdowns that happened in November and more recently don't seem to have had much of an impact so far. So yeah, it has happened quickly, although we knew it was coming. So that there's a part of me that kind of feels that, well, the writing was on the wall, so it's not that much of a surprise. But yet, now that it's here and we're seeing it day in, day out, we're trying to get more staff to come in. I suppose it's never the right time, is it? So,
No. And one of the things that we've been hearing is that less people are needing to be treated in intensive care. We're being much more successful at treating people in wards or with the drugs and the other therapies. Is that true? You haven't opened up your intensive care as quickly?
Yeah. So at the moment we have fewer people in intensive care than there were at the peak of the first wave. Yet we have more people in hospital than there were at the peak of the first wave. Now, usually intensive care admissions sort of lag 2 weeks behind everything else. So it might be that, in a week or two from now, especially given the situation in London, we might have actually more people than there were in the first wave in our intensive care units. So we don't know. I don't think that story is fully finished yet. But, there will be a proportion of people who got better because we are now better at treating this condition with certain medicines, with interventions like continuous positive airway pressure or nasal high flow oxygen. So it could be that we're seeing slightly fewer in the intensive care unit right this moment because of that, but it could also be just the timing of things that actually it will get worse. Remember, first time round we didn't know what the numbers in the community were because we didn't have rapid testing, so it might have been that there were 60,000 or 100,000 positive tests each day. We just don't know. Now we're counting it, so we don't really know what the conversion rate is from the levels in the community to the levels in hospital, to the levels in intensive care unit. We've only just established that denominator now.
I noticed on the BBC website a few days ago, there was a story about the age range of people who were ending up in hospital with COVID, and they were talking about multi-generational admissions, and Leicester was used as an example of a particular family where several people from the same family had been admitted. Is that something you're seeing in terms of the sort of demographic of who's coming into you now?
Yeah, I would say it's not unusual at all for people to say, you know what, oh yeah, my wife had it, my son's had it, or my grandma's had it, or my auntie's had it, or my, so absolutely. There's multi-generational involvement, and that, is not a surprise in some ways, is it? Because they are your, the immediate people that you are in contact with by and large, whether you reside with them or whether they are part of your bubble. And sadly, actually, I would say, unfortunately, some people, because of the experience of their family members in hospital who've perhaps come to the intensive care unit, who unfortunately have died in the intensive care unit, they're very reluctant to come to the intensive care unit because they associate that with a bad outcome. So, yes, we do see multi-generational involvement.
Yeah. When we were talking back in the summer, you started telling us a bit about the research that was going on into COVID and into long COVID. And obviously, we had a few more months pass since then. How is that research progressing around understanding the longer term effects of the disease?
Well, actually, before I get to the longer term effects, I want to just mention the shorter term treatments that have become apparent. So just in the last 24 hours, it's been released publicly that there are 2 drugs that might reduce mortality and length of time in the intensive care unit. So one is tocilizumab and one is sarilumab, and both of these drugs are used in rheumatoid arthritis and seem to, as I say, have an effect on critical illness from COVID-19. So that's fantastic news that, there's another 2 drugs along with dexamethasone that we can use. Now, these 2 drugs, I think, are going to be much harder to get a hold of and more expensive than dexamethasone. Dexamethasone has been around forever and is cheap as chips, whereas these 2 drugs are not. And that's going to have an impact in terms of supply lines and costs and everything else. So those two treatments are just been seem to be effective. And so finance departments up and down the country might need to know about that. And then the other thing that seems to be apparent is plasma from people who have had COVID infection. If you take that plasma and you give it to a person with an active infection, does it help? Because that plasma has antibodies. And it's looking like it doesn't help. And it looks like that arm of the research study nationally is going to be stopped as a result. And that's all news that just came about in this last 24 hours. So the point I'm trying to make is some of the research that was started with the first wave, has already borne fruit with dexamethasone, and now just in the last couple of days has borne fruit with some more information that will help during this wave. So that's fantastic news. Now, with respect to long COVID, we're still establishing number of people who get long COVID, what impact it has, and I suppose what treatment might be helpful. But the information from that trial is probably going to take some time to know what is helpful, what's not helpful, what the profile of people is. So it's harder. We can't really use that information practically right at this moment, and it might be another 6 months or longer before we have more useful information.
That's really good news, though, about the new treatments that are becoming available and understood. So that's really good to hear. Thank you.
Yeah.
You mentioned about the change in rotas and you're having the night rota put back in place. Generally, how are staff reacting to this new wave? I mean, I imagine many people are still tired from the first time round and the ongoing demands of COVID.
Yeah, I think that's true. They are, and I think that there's a few things, isn't it? I mean, all healthcare staff are part of the general community, and nobody's been able to sort of enjoy themselves in the normal way when they're not at work. So there aren't pubs, restaurants open. They can't go on holiday. They can't travel. So, you've sort of got two things. A, you're working all the time, and B, when you have time off, it feels like you can't really do much to unwind, probably, for a lot of people. So that's the first thing to say. The second thing to say is that whilst this is a second wave, the sort of gap between the first wave and the second wave isn't actually that long. It was like a month or two. We had a few, maybe 2-3 weeks where we had nobody with COVID in the intensive care unit. But because of the, rightly so, the need to stand up services for patients who didn't have COVID, all the people who didn't have their cardiac surgery or their other surgeries, people were still working in between waves. So it does feel as though there's not really been the downtime for anybody. And, when this wave finishes, I'm sure the directions that we'll get is that, we need to stand up services as quickly as possible. There's not really and you can't do that with healthcare, can you? You can't say, well, actually, everybody in the health service have 3 months off. You just can't do that. So I think, unfortunately, I think the workforce is going to be tired for a long time. And with this wave, I would say what is perhaps a little bit different is because we are trying to run other services in parallel more than we did in the first wave. It means there's fewer staff around to be released into those services that have got the greater workload. So in the intensive care unit, for instance, or respiratory wards or other medical wards. You don't have any extra staff coming from anywhere else because many of those services are trying to run some kind of skeleton service that they didn't the first time round. I think the other thing that helped the first wave was the weather, actually, and the light. And we're in, the deepest, darkest winter, and it's dark, and so I don't think that really probably helps people. But again, I think we just take one day at a time, 1 week at a time. That's probably the best approach, and that's the approach everyone's taking. And also be prepared for ongoing staffing shortages as we move forward, because people will be exhausted. There'll be some people's mental health will have been affected by this. and the ongoing kindness that people need to show each other, because it is a long haul, isn't it? One of the things that came up yesterday I was thinking about was that, it doesn't matter whether you're in healthcare, and even what you do in healthcare, or whether you are a school teacher or you're in business. This, everybody has different stresses, or people who are shielding, who can't go out. And so it's just recognizing that everybody is probably got their own cross to bear at the moment, and therefore, being kind to everybody is still very important, and we'll need to continue with that. And all the other gains that we made from the first wave with respect to technology and doing things different and being adaptable, all of those things still are very true today as they were then, and will need to continue as we go forward.
Yeah. So in terms of the services that you would normally be providing, you are still doing that to some extent. You haven't stood everything down like you did the first time around.
Correct. I mean, I would say even first time around, we were doing emergencies and urgent cases where we could, and we will endeavour to do that now. But the actual reality is, routine surgery will be postponed as pressure on having physical bed spaces increases. So yes, though, it's not like all other services will continue as normal. There will absolutely be a reduction in all other services, but key services like cancer services, urgent cardiac services, other services will continue on an ad hoc basis, based on priority. More so than the first wave, though. Yeah.
And in the news today, there's been an announcement that a third vaccine has just been approved for use in the UK, which is good news.
That's great news, yeah.
How long do you think it's going to take? And obviously there's the logistics of vaccinating people, but in terms of getting to a point where we can be confident in the country that we have got to a level of protection for this disease? I mean, I know that's sort of crystal ball, take a guess sort of a question, but...
Yeah. I mean, I suppose it's that sort of herd immunity thing. You have to have the vast majority of people protected by that vaccine. We know that COVID affects, young kids through to old adults. So it therefore has to be the vast majority of people, including kids, because otherwise, if you have, let's just say, 2 million people in the country who've never had the virus or the vaccine, well, they're still vulnerable, therefore, to the effects of getting COVID and therefore being hospitalised. And we've seen that, I think, I'm not entirely sure what the estimates are, but I think it's only, at least 2 million people, it's been estimated, have had COVID in England, maybe the UK as a whole. Maybe it's slightly higher. Let's just say 3 million. But it's wreaked havoc on the entire country and the NHS, the 3 million people who've had the infection. Therefore, if we've got a country of 60 million people, well, frankly, it needs to be almost everybody requires vaccination or to have had the infection to reduce the risk and the impact on healthcare services. So we've got a long way to go. We've got to, so it's great that, and rightly so, that we get the priority groups done. And I think the plan is for that to happen in the next few weeks. But that still only is relatively small portion of the population. And really, I think the big benefits are going to come when it is almost the entire population that's been vaccinated, which therefore is going to take much longer than the middle of February.
And I hadn't thought of it in terms of actually it's quite a small proportion of the population who have had COVID and have had this impact on the NHS. I think because we see these big numbers day in, day out around infections and so on, you think, oh, everybody's got it, everyone's struggling. But actually, as you say, it's a relatively small proportion that's already had this big impact. So there's certainly a long way to go on that.
And I think, for some of the people who might be listening to this podcast going, in the future, working in healthcare finance, we all have to plan for services, what a service is going to look like in the summer, what they're going to look like next winter. And I realise it is quite difficult to plan because the unknown is when can you start making assumptions about normal levels of activity. And what really threw the spanner in the works was the variant of the virus that became much more infective. Had we been working on, let's say, the original virus with a much slower infectivity rate, then it might have been easier to see the light at the end of the tunnel and therefore to start planning, etc., etc. But I think it does make it, unfortunately, a little bit harder as we sit here the first week of January, being able to really know when to start planning for the beginning of normality again. But that's what we have to do. We can't, just because it's very difficult doesn't mean we shouldn't do it. And clearly we need a plan A, B, C and D, and that's just the way it is.
And how are things with supply of PPE and oxygen and all the things we were hearing about early on in the pandemic that aren't so much in the news now?
Yes, I think for me, I've not heard a squeak about that. So I'm hoping that behind the scenes, it's all going really well, because I've not had any issues at all with being worried about lack of PPE. As our hospital, in terms of oxygen, again, I've not heard locally any issues at all about oxygen supply. That doesn't mean to say it can't happen, I suppose, in the future, but I'm hoping that the issues will have been addressed from the first wave. With respect to other equipment and drugs, I think it's, again, too early to say. I think we probably, I would imagine, have got ventilator capacity across the country. But there might be kind of things that certain drugs that we're using. So these 2 new drugs that I was talking about that become approved, I would imagine there'll very quickly be a shortage of those because everybody won't want them at the same time. And there might be, 1 or 2 other drugs and bits of equipment that become short supply again. And what we learned the first time round is oftentimes you can get round it with other drugs or other bits of equipment, or just thinking very hard about which people really need, equipment X or drug Y and what you can do instead. So I think, they'll all of that will still happen. But so far, I've not heard of any particular shortage of PPE or any other shortage of things that I use in the intensive care unit.
Brilliant. Thank you, Sanjay. Thank you for your time today. That was fascinating as ever.
Okay, great. Thanks, Sarah.
Thank you for listening to HFMA Talk. Don't forget to subscribe to this podcast to keep up to date with new episodes.